Hello everyone in Cardio Minds channel and Ramadan Mubarak for all of you. And today we are going to speak about a related topic to Ramadan regarding the fasting for cardiac patients who should not fast, who are allowed to fast, and what are the advice that we should give to our patients. I want just to emphasize on some points before I start the video. First of all, this is a consensus opinion from most of the cardiologists because we don't have clear recommendations or guidelines regarding who should fast and who should not fast in Ramadan. We should, after this, individualize our decision according to the clinical situation of the patient versus his or her desire. Because sometimes you may advise your patient that he should not fast, but the patient insists on fasting. In this case, I should respect the patient's desire, but after I explain to him all of the risk, and if he insists, I should give him the precautions, how to minimize this risk as much as we can. And the third thing that we are focusing here on the cardiac disease. Sometimes you may advise your patient that he can fast from cardiological point of view, but the problem is that he has another comorbidity, like for example, chronic kidney disease. So in this case, I should advise him to go to the specializing doctor to give him advice regarding this comorbidity. Can he fast or not? We will divide our video into 5 points. First thing, what are the challenges with fasting in cardiac patients? What are the false beliefs? Which cardiac patients should not fast and who are allowed to fast? And the last thing, what are the instructions you are going to give to the fasting patients? First of all, what are the challenge or the problem with fasting in some cardiac patients? The first problem is the hyperviscosity due to dehydration resulting in hemoconcentration, which may increase the risk for thrombotic events in patients with atherosclerotic cardiovascular disease, increasing the risk for myocardial infarction, stent thrombosis, or cerebrovascular stroke. The low blood pressure that is pronounced in some cardiac patients to the degree of hemodynamic instability with dehydration, for example, patients with severe LV systolic dysfunction, severe mitral or aortic stenosis, and patients with hypertrophic cardiomyopathy with dynamic LVOT obstruction. All of these patients are highly dependent on the venous return and preload, so dehydration here may result in severe hypotension and hemodynamic instability in some cases. And the electrolyte disorders like hypokalemia or hypomagnesemia, which have clinical impact in patients with decompensated heart failure or acute coronary syndrome, so we should follow up these electrolytes. The last concern is that some patients may suffer from none or poor compliance to their medications. So they may forget some medications, they may skip doses. For example, if you are giving your patient 3 times per day medication, he may skip one of the 3 doses. And sometimes the patient may have inaccurate lifestyle in Ramadan, so he has poor timing and he cannot adjust the timing of the medication. This results in poor compliance. And another issue is the unhealthy diet that in many countries they suffer from this in Ramadan. For example, taking excess carbohydrates and fat, excess salt, desserts, sugar or artificially sweetened drinks, and sometimes heavy meal at the sunset, like after Maghrib. Or some patients may have very large meals resulting in post-sepal angina. There are some false beliefs regarding the fasting for cardiac patients. The first one of them is that cardiac patients should not fast in general. This is a completely non-scientific because not all cardiac patients are like each other. The word or the terminology of cardiac patient is a very broad term. We should determine what is the diagnosis of this patient and what is his clinical stage in order to decide whether he can fast or not. And another belief that fasting is dangerous in general for all cardiac patients. No, there are some concerns and some challenges with fasting, but not in all patients and not in all clinical stages. You should diagnose your patient precisely because in some cases fasting may be beneficial as it may help weight loss, adjusting the diet, smoking cessation. So in some cases fasting is beneficial for cardiac patients. And the fluid intake between sunset and Fajr, some patients may believe and some doctors may also confirm this false belief that the fluid intake would increase the risk of edema and dyspnea, so reduce fluid intake. This is completely wrong. You should keep an adequate fluid intake to avoid dehydration and hyperviscosity. So based on this information, which patients should not fast at least this year? Because I will not prevent the patients from fasting forever. I'm speaking about at the time being that their clinical stage of their disease is not allowing them to fast. For example, patients with active cardiac condition should be prevented from fasting at least this Ramadan. For example, in case of coronary artery disease, if the patient had acute or recent MI, either STEMI or non-STEMI, then the first months after the onset of MI, they should not be allowed to fast due to the risk of reinfarction. And patients with unstable angina, I'm speaking here about critical conditions. Patients with heart failure, if they are decompensated at the time being, they should not be allowed to fast. After they are compensated and they are compliant to the medical treatment, I can allow them to fast. Patients, of course, with acute pulmonary edema or cardiogenic shock who should be hospitalized and an intermediate or coronary care unit, in this case, of course, I will not allow them to fast because they are in critical condition. Patients with arrhythmia, if they are having incessant SVT or VT at the time of the tachycardia, they should not be allowed to fast. I'm meaning here incessant, not paroxysmal SVT or VT in general, because many patients have paroxysmal SVT, but in between the attacks, they can fast with no problem. If they develop the tachycardia and they should be hospitalized or going to the emergency department, at this case, they can be allowed to break their fast. Either case, they should continue their fasting if they are in sinus rhythm. Patients with rapid AF not responding to pharmacological rate control and the patient is symptomatic and distressed, of course, I will not allow this patient to fast and to dehydration. And patient with bradycardia indicated for permanent cardiac pacing, they are in critical condition and liable for hemodynamic instability, so they should not be dehydrated, and so they are not allowed to fast till they have their permanent pacing. Patients with valvular lesions like symptomatic severe mitral stenosis or aortic stenosis, they are highly dependent on the preload, so I should not compromise the preload by dehydration. Patients with severe mitral or aortic regurgitation complicated with decompensated heart failure, as we mentioned previously, if they are decompensated, they should not fast. Patients with infective endocarditis, they are in active sepsis, so they should have their perfect immune status based on the nutrition and good hydration, so they are not allowed to fast. And patients with hypertrophic cardiomyopathy with untreated LVOT obstruction, here we are also dependent on the preload, so I should not compromise it by dehydration. And the last disease category is a congenital heart disease. If the patient is having untreated cyanotic congenital heart disease, for example, untreated fallow, those patients are highly liable to hyperviscosity and thrombotic events, so they should be advised to break their fast till they have their surgical correction. And as cyanotic congenital heart disease complicated by decompensated heart failure or infective endocarditis, of course, logical point of view that they should not be allowed to fast till the control of these complications. Another group of patients who should not fast are those with high risk of stent thrombosis. For example, patients who had elective PCI in the last 1 to 3 months. And I mean here to write a time range, because some doctors may advise the patient to avoid fasting in the first months and others may extend it to the first 3 months to minimize the risk of stent thrombosis by fasting. Patients who had PCI for acute coronary syndrome, either STEMI or non-ST elevation acute coronary syndrome in the last 3 to 6 months, some doctors may adhere to avoid fasting in the first 3 months, and other doctors may extend the duration of prohibiting fasting till 6 months, especially in case of high-risk STEMI like GLP2 or more, patient who had left main PCI, patient who had multiple stenting or bifurcational stenting. In this case, we should advise them to avoid fasting in the first 6 months. Patient who had recent complex PCI, for example, severely calcific lesion, PCI to left main or CTO, or bifurcational lesion with crush technique, or those with bypass graft PCI, all of these procedures have high risk for stent thrombosis, so some doctors may advise the patient to avoid fasting till a specific duration. And patient with history of stent thrombosis on adequate antiplatelet therapy, of course, this patient, we should not jeopardize him by exposing him to dehydration. Patient with a stent malapposition, because it is very liable to thrombosis. And patients with evidence of hereditary thrombophilia who may have high risk for arterial and stent thrombosis, they should be prohibited from fasting. So after we mentioned the patient who should not fast, who can fast? Many cardiac patients can fast based on their clinical condition. For example, those with a stable coronary artery disease with the last PCI more than 6 months. If you have strict follow-up of this patient and he is compliant to medications with no chest pain, good function capacity, and no recent CCU admission, he can fast in Ramadan. Patients with compensated LV dysfunction or valvular lesion and they are adherent to their medical treatment and to the lifestyle modification, or patients with resolved infective endocarditis either by surgical or medical treatment, they can fast. Patients with paroxysmal tachyarrhythmias in between the attacks, so if they are in sinus rhythm, they can fast. Patients with persistent or permanent AF with adequate rate control and compliant to oral anticoagulation to minimize the risk of embolic complication, they can fast. Patients with bradycardia, but it is a benign type not indicated for permanent pacing, or they were indicated but after permanent pacing, they can fast. Some doctors may advise to avoid fasting in the first 6 weeks after pacemaker implantation because this is a period for lead maturation, but in general, after pacing, they can fast after this. Patients with compensated or asymptomatic acyanotic congenital heart disease, or patients with treated cyanotic congenital heart disease but after excluding high thrombotic risk, they can fast. But it doesn't mean that if your patient can fast that you are not giving him an instruction. You should advise him by specific instructions. For example, the importance of compliance to the medication and the adjusted timing to the degree that he should advise him which medication to take with iftar or with suhoor according to the medication is taken in the morning or in the evening, because some patients may misunderstand that if the medication is prescribed in general to be in the morning, so in Ramadan he will stop it. This is completely wrong, and so it is the doctor's responsibility to dedicate each medication to the iftar or suhoor. The diuretics in relation to sleeping time, so you should ask your patient at which time he sleep in Ramadan in order not to give the diuretic just before sleeping, which medication to be taken on empty meals, so for example half an hour before the meal or 1 hour after it, and which medications to be taken after meals immediately, for example ivapradine and rivaroxaban, and the emphasis on compliance to the indicated antithrombotics, for example clopidogrel, ticagrelor, or oral anticoagulation to minimize thrombotic events. You can reduce the loop diuretic doses if appropriate according to the clinical situation of your patient in order to keep the avolemic state and reduce dehydration if it is not allowed, so keep on the same diuretic dose but having strict follow-up for this patient. Advise the patient to have an adequate fluid intake of about 2.5 to 3 liters between sunset and fajr in order to minimize the risk of dehydration, and the amount to be determined according to the state of the LV function, either water, beverages, soup, amounts of fluids that he should take in order to avoid the hemoconcentration and the hyper viscosity. And the last thing, the advice on the healthy diet habits in Ramadan regarding the quantity, avoiding heavy meals, and the components of healthy diet to try to reduce as much as we can carbohydrates, fat, sugar, salt, and try to increase vegetables, fruits, whole cereal grains, olive oil. All of this contributes to giving the patient the supplementary minerals and vitamins essential for him and avoiding weight gain and avoiding any risk for atherosclerosis. So what is the summary of the issue of fasting for cardiac patients in Ramadan? First of all, we should be oriented with the challenges that the cardiac patient may face with fasting, like hyperviscosity and acute coronary events, or stroke, hypotension and electrolyte disorders. Some patients may have poor compliance to medications or unhealthy dietary habits. The false belief, like cardiac patients should not fast, fasting is dangerous for all cardiac patients, or we should reduce fluid intake between sunset and fajr. Which patients should not fast? We now know that patients with active cardiac conditions or patients with high risk of stent thrombosis should not fast. And based on this, we can conclude which patients can fast. And the last thing, what are the instructions for the fasting patient regarding compliance and adjusted timing of medications? Reduce loop diuretic doses if appropriate to keep the avolemic state, fluid intake of about 2.5 to 3 liters between sunset and fajr, and the healthy diet habits in Ramadan. Thank you very much for watching this video, and Ramadan Mubarak for all of you. And I am waiting for your opinions in the comments below the video in order to tell me about your experience with the cardiac patient that they had some problems with fasting, in order to expand our knowledge about how to instruct those patients. And if you are having other opinions for other cardiac disease that you think that they should not fast, please share me with your opinion in the comments below.